Thanks for joining today's NCCN patient webinar, Know What Your Doctors Know About Mantle Cell Lymphoma. This webinar is presented by NCCN. NCCN stands for the National Comprehensive Cancer Network, a not-for-profit alliance of 31 leading cancer centers across the United States devoted to patient care, research, and education. The NCCN Foundation is a nonprofit organization that raises funds for NCCN patient resources, including new and updated patient guidelines as well as patient webinars. These resources are funded using financial support from generous donors. The NCCN guidelines for patients are based on the NCCN clinical practice guidelines used by healthcare providers worldwide. They explain the same options for cancer care, but are written for patients and their caregivers, family, and friends. You can view and download free copies of the guidelines for patients from the NCCN website. Printed copies of the books can be purchased through Amazon. If you ordered a free book when you registered for this webinar, you should be receiving it shortly. The Know What Your Doctors Know webinars complement the NCCN guidelines for patients. They cover a series of topics discussed by expert presenters. Viewers will have an opportunity to ask questions to presenters during the second half of this webinar. Now, let's meet the presenters for today's webinar. First up is Dr. Ann Lacase. Dr. Lacase is an associate professor of medicine at Harvard Medical School and medical oncology at Dana-Farber Cancer Institute. Our second speaker is Sharon Kurtz, a certified physician assistant in the Division of Hematological Malignancies, also at the Dana-Farber Cancer Institute. Our third presenter today is Lawrence Fagan, the moderator of the ACOR online MCL community, and formerly a senior research scientist, now retired, at Stanford University. Dr. Fagan is also a 9-year survivor of mantle cell lymphoma. And now, without further ado, here's Dr. Lacase.
Thank you very much for the kind introduction. We'll be starting with an overview of what is mantle cell lymphoma. So as many of you probably know, mantle cell is actually quite a rare subtype of non-Hodgkin lymphoma, representing about 6% of all the cases, at least in the United States. It typically affects more men than women. Up to 75% of the cases occur in men, and is generally a disease of older adults with a median age in the middle 60s, but can affect younger and quite elderly patients. The name mantle cell lymphoma actually comes from the way it looks under the microscope. So depicted here on the right is what a lymph node looks like under a microscope. And you can see labeled mantle, and that is the mantle zone of the lymph node. And the cells that normally live there resemble the ones that we see in mantle cell lymphoma. So mantle cell lymphoma has a number of different subtypes that can act quite differently in their clinical behavior. You can see on the left is the mantle zone subtype, which is quite rare and has more of a rounded areas within the lymph nodes or areas of disease involvement. The mantle zone subtype tends to be slow growing, and many patients with mantle zone subtype do not need therapy when they are first diagnosed, which we'll discuss a bit more in a moment. The more standard subtypes of mantle cell lymphoma are the two in the middle, the nodular subtype, and by nodular we mean that there are these rounded areas within the lymph node. Diffuse just means that the cells are kind of spread out throughout the tissue and aren't forming those nodules. And then lastly is the blastoid. There's also what is called the pleomorphic form. These tend to be subset of mantle cell lymphoma that grows more rapidly, and under the microscope the cells look larger and are dividing more rapidly. So mantle cell lymphoma is, in almost all cases, is characterized by a translocation of the chromosomes within the tumor cells. This does not mean that all of the cells in your body have this translocation. It only occurs in the cells that are the mantle cell lymphoma. And what happens is this protein that normally lives on chromosome 11 called cyclin D1 breaks off and reattaches to the chromosome number 14. And what this leads to is significant overproduction of cyclin D1 because chromosome 14 is a very active area on the chromosome where immunoglobulins are made. So you get a lot of extra cyclin D1 protein, and this actually causes cells to divide abnormally. So mantle cell lymphoma is one of the lymphomas that we actually have quite a good understanding of the biology. And this is a little bit different compared to many of the other lymphomas, which are probably much more complex in their biology. So how do patients present with mantle cell lymphoma? Well, most people present with the disease involving many areas within the body at initial diagnosis. And we don't think of this like solid tumors as starting in one spot and then metastasizing to others. Because lymphomas arise out of bone marrow stem cells and involve lymphocytes, which travel everywhere in your body, and you can see here, this is sort of the network of lymph nodes that form the lymphatic system. These cells go to the bone marrow, they go throughout the blood and into the spleen and other places. So mantle cell lymphoma very typically involves many different areas, and we'll talk about the formal staging on the next slide. But about 70 or even 75% of patients present with advanced stage disease. The majority of patients will have lymph node involvement, up to 3/4. These symptoms, which are defined as fevers over 100.5, drenching night sweats, meaning you need to get up in the night to change your clothing because you're uncomfortable, and weight loss of more than 10% of total body weight in the preceding 6 months. These occur in about 1/3 of patients and tends to be in patients who have a high burden of lymphoma or lymphoma that may be that blastoid or more aggressive subtype. About at least 60% of patients will have involvement in the bone marrow, and the gastrointestinal tract is very commonly involved. Sometimes the first presentation of mantle cell lymphoma may be in the colon when someone has a screening colonoscopy. These very small polyps can be seen, and on biopsy, these show mantle cell lymphoma. It can also involve the cecum or appendix or stomach or really any part of the GI tract. There is a specific subtype of mantle cell which tends to be slower growing, at least initially, called SOX11 negative. SOX11 is a protein that our pathologists can look for on the cell surface. And patients who have this subtype of mantle cell often present with disease out in the blood, which is very common, an enlarged spleen, but lack of involvement of lymph nodes. This often grows very slowly, and we can observe patients in some situations for many years, but rarely it can transform into a more aggressive disease when it acquires this protein called TP53 mutations, and then these patients will typically require treatment. So the staging of lymphoma applies to all lymphomas and was actually devised for Hodgkin lymphoma, which is an orderly disease which tends to involve sequential lymph nodes. So the staging sort of makes more sense in Hodgkin's, where in non-Hodgkin lymphoma, it tends to be in more disseminated areas. So the staging goes if you have one lymph node site anywhere in the body or one non-lymph node site, that's a stage 1. If 2 or more lymph node sites are in either the neck and chest or below the diaphragm in the abdomen or pelvis, that's stage 2. Stage 3 involves lymph nodes on both sides of the diaphragm, here that cuts the body in half, and includes patients who have spleen involvement. Stage 4 means if the bone marrow or the GI tract or any non-lymph node site is involved. And as I said, the majority of patients with mantle cell present with stage 3 and 4 disease. And again, this doesn't really tell us a whole lot about the disease. It just sort of tells us where it is at baseline so that when we assess the disease after treatment, we know where to look. So there are many different treatment options for patients with mantle cell lymphoma, and very encouragingly, these options are just getting better and better over time. But the first question to really address in a patient who presents with a new diagnosis of mantle cell lymphoma is treatment really needed at all? I mentioned that SOX11 negative subtype. Many of those patients, there is no benefit to treating early, and there have been studies looking at patients who have low burden or slow growing or asymptomatic disease. And these patients live the same amount of time as people who are treated right away, even if they are undergo what we like to call active surveillance, or some people will call watch and wait or watch and worry. We try to tell patients, let us worry, you don't worry, we will keep track of you and see you through this. It can be sometimes difficult to initiate a non-treatment approach. It takes a lot of sort of time, and generally over time it becomes more comfortable to be on active surveillance. The proliferation index, or Ki-67 fraction, tells us how fast the cells are growing. So when patients have a low Ki-67 fraction and don't have symptoms or asymptomatic, that may be a good situation for active surveillance. If the blood counts are normal, if the lymph nodes are not large or causing trouble, if the spleen is not significantly enlarged. When the spleen becomes large, patients can have pain on the left side of the lower or mid to upper and even lower abdomen, or can lose weight from getting full early. So if these things are, if you don't have any of these indications for treatment, active surveillance is a good option. As the disease progresses and patients develop symptoms or difficulties with blood counts, then we would then advocate for initiating treatment. So in terms of frontline treatment, we sort of divide this up into what is the state of the patient. Is the patient fit and younger? And by younger, we mean under 70 to 75 and doesn't have a lot of problems with other organ function. So patients typically who fit into this category undergo what we call induction or initial chemotherapy with the goal of getting rid of as much disease as possible. Many patients will then undergo a stem cell transplant, and this is basically a way of intensifying the chemotherapy with the goal of eradicating any hidden cells that were not killed by the initial induction treatment. This is also referred to as high-dose chemotherapy with stem cell rescue, because if we gave you high-dose chemotherapy and did not take out stem cells, generally collected from the blood, and store them away, we would obliterate your bone marrow. So what we can do is protect those cells from the high-dose chemo and then give them back once that chemo has been completed. And patients are in the hospital for a couple of weeks and generally do quite well with this. And then there's evidence to suggest if you give Rituximab, which is part of the induction chemotherapy, this is a monoclonal antibody or protein treatment that basically binds to a protein on the surface of the tumor cells and helps your body eradicate those cells. And there's studies showing if you give maintenance after stem cell transplant for 3 years, the outcomes are better than if you do not use maintenance therapy. There are a number of different induction regimens that are used, and they've not been compared for the most part head to head. We at our center tend to use Bendamustine plus Rituximab, which is that targeted drug, also known as immunotherapy, followed by a combination of a drug called cytarabine with Rituximab. But there are other combinations that are very active, and they're listed here: the Nordic regimen, DHAP, which includes Ara-C and a platinum drug, and R-CHOP or R-hyper-CVAD are all options that you may have heard about. So for patients who are older or who are not interested in a stem cell transplant or have comorbidities, we often use combinations, including Bendamustine plus Rituximab. Sometimes we'll add other drugs to Rituximab, such as lenalidomide, which is an oral chemotherapy drug, which has multiple different effects on tumor cells. Patients then may go on to receive Rituximab after the initial treatment. This may be a little bit controversial in terms of how well this works after a full course of Bendamustine, but is something that we often do. I suspect in the near future, these options may be changing based on some of the really active drugs that we now are using in patients who've been previously treated. So these include the BTK inhibitors. BTK stands for Bruton's tyrosine kinase. It's a pathway protein in the mantle cells that is responsible for making cells grow and divide. There are 3 different BTK inhibitors that are approved: Ibrutinib, Acalabrutinib, and Zanubrutinib. Ibrutinib was the first and really changed how we thought about treating relapsed disease. These are oral drugs. They tend to be well tolerated. Ibrutinib, being the oldest drug, does have potentially more side effects than the other two and is more likely to cause atrial fibrillation. That's what's shown here on this EKG strip. This is an irregular heartbeat, which is usually not a big deal, but will need to be treated in some patients. It also can cause bruising and possibility of bleeding, but these are very active drugs, and I suspect soon we will be seeing them being incorporated into the upfront treatment of patients who need treatment. CAR T-cell therapy is something that many of you may have heard about. This is something that's really arisen over the past 5 years or so and is really very interesting. So what happens here is that we can collect T cells. T cells are immune cells that are in your body. We can collect them from the blood, just like donating blood or platelets. These cells are then sorted, and the T cells are sent out to a company who then modifies these cells to express what we call a chimeric antigen receptor on the surface of the cells. So this is a protein that recognizes CD19, which is another protein on the tumor cells. These cells are then grown up and multiplied. Patients then come back once we have received these cells and get some low-dose chemotherapy to prevent rejection of these cells. And these cells are then given back to the patient. And what they do is they seek out and attack the CD19 positive mantle cells and hopefully get rid of all of them. And this is now FDA approved in patients who have been treated previously with mantle cell lymphoma, and is something that we use typically after patients have had initial treatment and a BTK inhibitor. So CAR T-cell therapy can be associated with significant side effects. Fortunately, because we've been using this approach in other types of lymphoma for a number of years now, we've really become much better at treating side effects. The two main categories of side effects that we see are, first, what is known as cytokine release syndrome. When these CAR T cells interact with the mantle cells, they release a lot of basically hormones into the system, which can cause things like flu-like symptoms, fast heart rate, low blood pressure, and can affect organs such as the liver and kidneys and bone marrow. But generally, we're able to manage this quite well with drugs that block one of these hormones known as IL-6. We also sometimes need to use steroids, but generally, patients can be managed very well with cytokine release syndrome, and the most common thing we see is fevers and sort of fatigue. The other side effect, which is a little bit less well understood, is what we call neurotoxicity. So these cells can release these hormones into the brain and cause anything from confusion to stroke-like symptoms, seizures, swelling in the brain, or bleeding. And again, we have, over the past years, really understood this much better, and particularly how to manage it with very aggressive steroids and help from our neurologist and subspecialist. And it is very uncommon that patients will have very serious or fatal complication of CAR T cells. And we have one CAR T cell product that is approved now in mantle cell, but there are some other CAR T cell products that should be coming along very soon for approval that appear to have less toxicity in terms of particularly neurotoxicity. So, keep an eye out for that. And we have a number of new kinds of CAR T cells that are being developed. Donor stem cell transplant, or allogeneic stem cell transplant, is another potential treatment for patients with mantle cell lymphoma, usually used in people who have been significantly pretreated. Often patients may, before CAR T cells, this would have been our next line of treatment in patients who were no longer responding to BTK inhibitors or other treatments, possibly venetoclax. Now we're doing fewer allogeneic transplants because of CAR T cell therapy, which we hope may have the ability to keep the disease in check in the long run. So what happens here is a donor is identified, oftentimes a family member. This can also be an unrelated donor. We have a huge international registry of people who have signed up to be donors. The cells are removed from the blood, just like, again, donating blood or platelets. The patient then is given chemotherapy to reduce as much of the lymphoma in the body as possible, as well as to kill off their own T cells. So what the new cells are then reinfused, they're not destroyed. And with this comes the risk of what's called graft versus host disease. So those new cells can recognize the patient and cause trouble with a number of different organs. This again is an area where there's been a lot of improvements over the past decade, so it has become safer and safer. But again, we're not using this as often as we had been due to the availability of all these new treatments. So this is a study that I wanted to mention that is ongoing in the United States, and I think is a very important study. So we now have these ways of identifying after patients get initial treatment, whether or not we've really eradicated all of the lymphoma. And that's by doing what we call MRD, or minimal residual disease testing. And this can be done in the blood, and basically a probe is made using the patient's initial tumor biopsy specimen. So what happens in this study is patients enroll. This probe is looked for. If it can be identified, then they will go on to the randomized part of the study after getting induction treatment. If patients have no evidence of residual disease by PET scans, bone marrow biopsy, and by this probe, we consider them to be MRD negative complete remission. Those patients are then randomly assigned, so half of patients will get an autologous stem cell transplant plus rituximab, and the other half of patients will get rituximab alone. The reason we are doing this study is we are trying to ask the question for those patients who really have the very best responses to initial therapy, does the autologous stem cell transplant provide additional benefit in terms of how long patients stay in remission? We do not know the answer to this question yet. And, I think maybe some of you on the call have decided to enroll in this study, and we know that patients inevitably have a preference of which of these arms they might want to end up on. Some patients say, I want that stem cell transplant because I want it the most aggressive treatment possible. Other patients say, ugh, if I don't need that 3 weeks in the hospital and that aggressive treatment, I really hope I get the rituximab alone. But we really, in order to do these kind of trials where patients are assigned randomly to 2 treatments, in our hearts and minds, we really have to believe that we don't know that one or the other is better. And we really hope that by patients participating in this study, we'll be able to answer this question, and it will be of great benefit to those patients coming down the line. So it's really been very gratifying to see how well this study has been accruing nationally. We've had a lot of patients at Dana-Farber participate, and we are so grateful for the patients who have decided that this is the right option for them. Some patients, this is not, it may not seem like a comfortable study. We totally support that, but this is a study that is going to help us better understand the field. For patients who have evidence of residual disease, they get the standard treatment with the transplant and maintenance rituximab. So there are a number of other unanswered questions in the field that fortunately we are moving towards being able to answer. TP53 mutations, which I mentioned before, TP53 is a protein that is involved in many different cancers. And when it is mutated, it tends to suggest that treatments with standard chemotherapy may be less active and of less benefit. So we don't know for patients who have TP53 mutations what is the best approach, but we do know that stem cell transplant does not appear to be the best approach for these patients. So we are doing clinical trials looking at novel treatments like the BTK inhibitors in combination to try to sort this out. Another rare but difficult to manage complication of mantle cell can be when the disease involves the brain or central nervous system. Fortunately, we do have treatments, including drugs like cytarabine and the BTK inhibitors, which do have activity. And early data suggests that CAR T cells may also be an appropriate treatment for patients who have mantle cell lymphoma that involves the central nervous system. So future directions, I've sort of highlighted this already, incorporating BTK inhibitors and newer drugs in the frontline setting. Trying to ask, so for patients who may have TP53 mutations or relapse early or are not responding appropriately to initial treatment, can we incorporate CAR T cell therapy earlier? There are a lot of new drugs and immunotherapy options that are out there in clinical trials, and we expect those are going to be moving forward very rapidly. And then lastly, using MRD-directed therapy to really understand the biology of the disease to best tailor the treatment to our individual patient. And I think that's always our goal in oncology, is to work together with patients to come up with what is the best treatment option for them as an individual. So with that, I'll thank you for your attention and hand it over to our absolutely fantastic physician assistant in our lymphoma group, Sharon Kurtz.
Thank you, Anne. It's nice to be with you today. I'd like to follow up with Dr. Lacaze's talk and talk a little bit more about the mantle cell lymphoma therapies and specifically side effects and treatment of the side effects. As Dr. Lacaze mentioned, there are many mantle cell lymphoma therapies that your provider may recommend that you receive. This can include chemotherapy, monoclonal antibody therapies such as Rituximab, steroids. There can be oral targeted agents, radiation, sometimes stem cell transplant, as we mentioned, and CAR T-cell therapy. Treatment side effects can include multiple organs and multiple organ systems. Starting with the brain, one of the most common side effects we can see associated with mantle cell lymphoma therapy can be a condition called chemo brain or cognitive dysfunction. You may have heard of this, and many patients describe this as sort of a fuzziness or difficulty with memory after completing therapy. Risk factors for this condition include patients who have received chemotherapy or patients who have received brain or skull radiation. Oftentimes, research has shown that patients who develop chemo brain have a pre-existing cognitive dysfunction, and so they've had difficulty with their memory prior to treatment. If this does develop, then what we do is we refer a patient to a neuropsychiatrist for neurocognitive testing so that we can identify certain deficits and recommend treatment. There may be also cardiac side effects that we see for patients who've received chemotherapy with anthracyclines at a dose of greater than 350 milligrams per meter squared. We can see the side effect and complication of congestive heart failure or fluid overload. And so this requires treatment with a cardiologist. The BTK inhibitors, including atrial fibrillation in particular, as Dr. Lacaze mentioned, we can see atrial fibrillation and more rarely ventricular tachycardias. Rarely patients who receive mediastinal radiation therapy can develop what we see. We can see pericardial or valvular damage of the heart, and patients who receive radiation to the neck, we often can see long-term and late effects of carotid vessel disease. And of course, any combination of these therapies, patients are at higher risk for these heart effects. For treatment of these conditions, for any patient who has received anthracycline chemotherapy, we recommend a repeat echocardiogram 12 months after the completion of chemotherapy to assess the ventricular function. For patients who have received radiation therapy, we recommend both examination for carotid breweries when you come for your examinations in clinic, as well as carotid ultrasound follow-ups. For patients who have valvular dysfunction, we recommend antibiotic prophylaxis prior to surgeries or other invasive procedures. And for any condition that's difficult to manage, certainly we recommend referral to a cardiologist. And we also recommend that patients modify any other cardiac risk factors that may contribute to heart disease. So these are modifiable conditions such as high blood pressure, managing cholesterol, managing diabetes and obesity, and stopping smoking. For lung side effects, for patients who have received kinase inhibitors such as Ibrutinib or acalabrutinib, these patients can be at higher risk for pneumonias, including fungal pneumonias, for which we recommend antibiotics or antifungal treatments. For patients who have received monoclonal antibody therapies such as Rituximab or obinutuzumab, these patients can develop pneumonitis, which is an inflammatory condition of the lungs. And patients who receive radiation may also be more prone to pneumonitis. For pneumonitis, we recommend steroids for treatment of this and also referral to a pulmonologist. For GI side effects, one of the most common side effects we see with these treatments can be nausea and vomiting. There is both acute nausea, which occurs within the first 24 hours of treatment, and delayed nausea, which can last up to 5 days after treatment. Patients who are at risk for nausea and vomiting are those who have received chemotherapy, particularly doxorubicin can be a culprit. Also, BCL2 inhibitors such as venetoclax, we can see nausea and vomiting. And BTK inhibitors, we see nausea and vomiting, but less frequently. Interventions, we recommend anti-nausea medicines such as Zofran, Zyprexa, sometimes Ativan or lorazepam. Steroids can be helpful. We also recommend patients eat smaller, more frequent meals. Keeping something on your stomach can be helpful. Also, sometimes changing the timing of when you take oral drugs can be helpful. For example, taking venetoclax at bedtime instead of in the morning often helps with nausea. Staying well hydrated, drinking at least 2 to 3 liters of non-caffeinated fluids a day, and treating constipation. We can also see side effects of constipation and diarrhea. Vincristine is a chemotherapy drug that we often see complications of constipation. For these patients, we recommend laxatives and stool softeners. Exercise can also be very helpful in combating constipation and staying well hydrated. The kinase inhibitors, such as Ibrutinib or acalabrutinib, as well as venetoclax, the BCL2 inhibitors, can contribute to diarrhea. And so anti-diarrheal medications such as Imodium, and again, staying very well hydrated. There can be bone and bone marrow effects. For patients who have received steroids, we can see patients develop osteopenia and osteoporosis. Typically, the longer you're on these drugs, the more prone this is to happen. So we recommend bone density evaluation, as well as calcium and vitamin D supplements, weight-bearing exercise, and cessation of smoking. For patients who have received chemotherapy or radiation therapy, we can see low blood counts, including anemia, low white counts, low platelet counts. And so for these patients, we recommend blood or platelet transfusions if that's necessary, or injections such as growth factors like Neulasta to boost white blood cell counts if needed. And then for all patients who have received treatment, we just recommend ongoing CBC monitoring to screen for secondary leukemias or myelodysplastic syndromes, and this typically occurs later on, several years after treatment. The fertility side effects that we see with mantle cell lymphomas are less common, just given the demographics of patients who are treated. As Dr. Lacase mentioned, the median age of mantle cell lymphoma patients are in their 60s, but there can be younger patients who are affected, those who receive chemotherapy, receive radiation to the pelvis or the gonadal area, and all patients who are greater than age 30 at the time of treatment are at higher risk for infertility or premature gonadal failure, such as menopause, low sperm counts, or just inactive sperm, and then also early menopause. So we recommend fertility referrals if this becomes a major concern or difficult to treat symptoms. And sometimes, often in our clinic, we ourselves just help with treatment of the menopausal symptoms, such as hot flashes and vaginal dryness, and recommend sometimes testosterone replacement in patients and males who have sexual dysfunction. There can be immune effects related to therapy. Patients who receive monoclonal antibody therapy, particularly those patients who are on long-term maintenance Rituximab, those patients who are receiving that 3 years of maintenance Rituximab after transplant, we can often see low antibody levels or low IgG levels in the blood. If this is accompanied by frequent infections, such as sinus infections or upper respiratory infections, then your provider may recommend a replacement IV immunoglobulin that it can be administered to boost those levels and hopefully prevent infections. For other patients who are on targeted therapies, they can be at higher risk for pneumonias, and so or viruses such as herpes or herpes zoster. So your provider may recommend antiviral therapy or antifungal prophylaxis. We also recommend that all of our patients receiving therapy for mantle cell lymphoma stay up to date with vaccines as recommended, and this includes annual flu vaccine, pneumonia vaccines, including both Prevnar and Pneumovax, also Shingrix according to the CDC guidelines, Any patient who has had a spleen removed or has had radiation to their spleen, we recommend revaccination for these encapsulated organisms listed here. And then patients who have received bone marrow transplant, we recommend revaccination of the childhood vaccines according to the ASBMT guidelines. Fatigue is a common side effect of treatment. Many patients experience this, and it's just because of what we've discussed that there are many side effects that can be either metabolic or physical or functional. And this can just lead to a patient not functioning as well because of the fatigue. The research has shown that depression and anxiety can be associated with fatigue, and so certainly screening for this should be done. Exercise can be very helpful with bolstering energy levels and stamina. And also we discuss sleep hygiene, and there may be in your institution a sleep clinic to which you may be referred, which can also be a helpful resource. We recommend health maintenance, just routine health maintenance, such as regular exercise. The time frame for that is 150 minutes or 2.5 hours a week of moderate intensity cardiac exercise. Maintaining your weight with an optimal BMI, cholesterol screening, heart healthy diet, and moderating alcohol. The American Cancer Society recommends no more than 2 drinks for men in a 24-hour period and 1 drink for women in a 24-hour period, and trying to limit that to 3 days a week if possible. Avoiding smoking, of course, the vaccinations, skin protection when you're outside to minimize secondary skin cancers, and bone density evaluation. And lastly, I just wanted to mention COVID, since this is so prevalent and such a concern, particularly among patients who are receiving treatment for mantle cell lymphoma, but all lymphoma patients in general. We are recommending that all lymphoma patients receive a COVID vaccination. However, patients with lymphoma, particularly those receiving therapy with Rituximab or monoclonal antibody therapies, are at high risk for not mounting an adequate immune response to the vaccine. And so we are still recommending that all our patients wear their masks and social distance, avoid dense crowds. There's a Leukemia and Lymphoma Society vaccine study in the immunocompromised to assess for blood antibody levels for COVID, to try to get an idea as to whether or not patients are responding to these vaccines. But in general, we're still recommending just the COVID precaution measures of mask wearing and social distancing. Over the past month, the recommendation for the COVID booster has come out, and we are recommending that any patient who has received a messenger RNA COVID vaccine receive the booster as soon as possible. There's no need to wait that 8 months. So I'm going to now pass this along to Larry from the patient perspective.
Thank you. I'd like to speak both from the patient perspective, but also in my role as a moderator of one of the online communities, and also as a retired researcher that was involved in a lot of medical and computing research. So I have 3 key points I want to get across. The first is we really encourage you to join the online groups to get both support from other people who are going through the same situation, but also to learn more about the disease and about how you can help work with your providers and provide a kind of shared decision-making process. I also wanted to talk about understanding why the statistics that you read online don't tell the whole story. I know when I was first diagnosed, first thing I did is Google mantle cell lymphoma, and I was very concerned. And whenever someone joins one of these online communities, the first thing they say is, I went online and I was concerned. And then the next person says, don't Google. And my point is, there's a lot of information out there that's useful, and you need to understand why the numbers were bad and are getting better. And we'll talk a little bit about what that process is all about. So I'd like to encourage all of you to join online support groups. Actually, a lot of you probably found out about this talk through the online support groups where I was putting messages out. And I think there are some very good benefits, and there's some things you got to worry about in terms of online support groups. The benefits are that you have a place where you can start to learn more about the disease. You can particularly ask questions. I'm about to do CAR T. What has been your experience with that? I'm getting Bendamustine for the first time. What is it you wished you had known when you went into to start that chemotherapy? There's a sense of social support that we get when people realize that people are having a hard time, both for psychological reasons or that they have been through treatment after treatment and it's just a difficult situation. And then there's the rest of life, which right now it can be pretty difficult on top of that, and getting support from other individuals. I think that one of the people that we forget about, since we typically concentrate on the person with the disease, is that there's the caregiver who's also going through a difficult time. They are trying to take care of you and take care of themselves and take care of the family possibly, or other relatives. And so it gives a chance for caregivers to say, you know, this is difficult for me, or what do I do, or what worked for you as a caregiver in this situation, particularly these difficult situations like stem cell transplants, or CAR T. And I think it's very important to realize that, as was pointed out in the lectures, there's many different types of mantle cell lymphoma as it is presented. And so when someone says, this is what happened to me, you know, I got this kind of response, you have to take that with a grain of salt, because you may be very different. You may have a situation that is less aggressive or more aggressive. You may have other medical problems. And so you have to really be careful to make sure that this situation that's being described by someone else matches your situation. Well, the good news is there are actually many online communities. I've counted close to 20. So for a rare disease, it's amazing what the options are. And some of them are organized around where you are in the treatment plan. For example, there's one for people who are just in that watch and wait situation that was described earlier. Others are organized around where you're getting the treatment. So for example, those who get treatment at MD Anderson have a group called MCL at MDA on Facebook that's specific for people so that they can meet up while they're waiting there, so that they can share information about where can I stay overnight. Different drugs are approved in different countries. Different experts exist in each of these countries. And so, for example, there's an MCL support group UK that's also on Facebook, which really emphasizes their specific treatment situation. There's also groups that have been organized around the type of support. So for example, MCL The Journey, which is also a Facebook group, concentrates on some of the psychological issues and the path that people are taking as they get the various treatments and are faced with many of the decisions. And then there's some general groups like the Facebook group Mantle Cell Lymphoma Support, which has over 3,000 mantle cell patients who are signed up for that. And the ACOR group that I help moderate, which has about 400 patients. If you want to find more about these groups, we put together some links specifically for mantle cell patients. You can see those links here and they're on the slide sets. And also there's a group called Patient Power, which also has listed a number of the mantle cell support groups. So I think that one of the most important things that you can do is learn more about the disease. I think that the days of the doctor knows the answer and will just say you pick is changing to the point where you can learn more about it and you can understand what's going on and really learn at least what to expect. I think one of the things that happened to me, for example, was I got to the end of that first 6 months of Bendamustine and Rituximab, and I said, oh, I'm done. And I went and saw my oncologist, and she said, oh no, that after the initial treatment, there's either going to be some consolidation treatment like a stem cell transplant, or you're going to have rituximab maintenance. We're not sure if it makes a difference, but it worked in this other disease, so that's the next step before you stop treatment. So I was surprised, and had I understood kind of the flow, which is described in these talks and also in the pamphlet, that really helps you to keep track of what's going on. I think an important question to ask is, for patients who are like me, what advantage do I get for this treatment? Will give me 2 extra years of pretty good life, but how hard is that treatment? What effect will it have on my body? And so the idea would be to customize the treatment as all providers are trying to do now. And then learn about from the online groups, what is their experience with the different treatments? And I see this question come up all the time now, where someone says, I'm about to start this. What do I need to know? The other thing I think it's important to learn about is the language of the medicine. So there's Ki-67 and TP53 that have come up in the talks. Those are things that are going to make changes in your treatment. And then there are statistical terms like overall survival or progression-free survival, many of which are pretty arcane. And I think learning about what those are will help you. But you can spend all day long just trying to become a mini expert on mantle cell lymphoma. And I don't think that's really a good idea, because the whole reason for the treatment is so you can go back and have as normal a life as possible. And so I think that what we're trying to do here is to learn some, but at some point you've got to use it to just go back to your normal life. So one of the things I think that's super important is to understand the statistics, because in these talks and online, people are going to throw a lot of statistics around. There's some important things to think about. The first thing is that when they take a clinical trial, that they're talking about a population of patients. They're talking about a group of patients. And the statistics refer to that group. They don't refer to you as an individual. Even if the median, the average person has 5 years before their MCL comes back in that clinical trial, that doesn't say that you are going to have 5 years. So I think that's important. And that's why the statistics don't exactly apply, although they give you a hint of how most people did. I think that it's very important to understand that there's a long development process for creating these treatments, and we'll talk about that with regard to CAR T in a second. So the statistics that you see when you look online are derived from some time ago, and let's look at that for CAR T. So CAR T was first demonstrated in the lab just about 20 years ago, but it took 10 years for CAR T to make it out of the lab. And for example, the first pediatric patient named Emily was treated in 2012. Well, the first approvals for any kind of cancer at all of using CAR T didn't happen until 2017. And for mantle cell lymphoma, that was only approved in 2020, last year. So if I want to ask a question, even going back for the pediatric patients that were treated starting in 2012, what is the 10-year survival for pediatric patients who receive CAR T? We may not have enough patients. That first patient isn't even out 10 years. So we have to wait until there are enough patients, typically half of the patients that were in that study, before we can actually calculate how well that treatment works. So there's almost a 20-25 year period between the idea for a study and when it starts to affect the statistics. Now, the way, in addition to doing statistics for studies, there's something called a patient registry, where they record all the patients in a state with a particular cancer. And you can then, those databases can be searched. But even if CAR T cured everybody, it's like having a C average and then you get an A, and how many A's do you need to kind of bring up your grade point average? Because as they keep track of all the patients, only a handful of patients have had CAR T with mantle cell lymphoma. And we have to follow those for a number of years to see how they did. And so all the other treatments that are out there, which are good and getting better, may not be influenced by CAR T for another decade. So a good question of how does CAR T work in mantle cell lymphoma may not be answered till 2030. And so that's the reason that the statistics you see don't really reflect what's going on, because changes are happening, but they don't, it takes a long time before they change the data when you go and calculate from the registries. So in summary, join an online group or join a few of them. I think I'm in like 10 of them. Learn about the details of mantle cell lymphoma and be able to ask questions of group members and your providers. Understand the statistics, but don't be afraid to search online. Those numbers represent older studies that are maybe as much as a decade out of date. And remember to have your regular life, because if you spend all your time studying mantle cell, you're not going to enjoy it. Thank you.
Thank you, Larry. That was some great information. And thanks to all our other presenters, Sharon Kurtz and Dr. Lacasse, for their presentations. Okay, now it's time for the Q&A session. Okay, so we have a few questions already. We'll just go in order here. The first one is from Eric. He says, first of all, I'm thinking most of these questions are going to go to Dr. Lacasse. Eric asks, how do you sign up to be a donor for CAR T? He says, I'd like to spread the word. I wonder if he meant allogeneic stem cell transplant.
I think so. It's confusing. So CAR T, chimeric antigen receptor T cell therapy, uses a patient's own T cells, whereas donor stem cell or allogeneic stem cell transplant uses a donor, stem cells or bone marrow. So right now there are registries internationally for donors for allogeneic transplant. So we are always encouraging people to sign up for that, because you may be a match for someone in need. But for CAR T, we use patients' own. At least right now, there are some allogeneic CAR T cells that are, in clinical trials, but they, we don't need to get specific donors. You don't have to match them in the way that you do for an allogeneic stem cell transplant.
Right.
And for patients who are interested in donors, being a donor, Be the Match is one organization. There you can search online, they'll mail you a swab, and you can just do a simple cheek swab, send that in, and then you're on the registry and would be contacted to be a donor.
Good one, yeah. Okay, Eric has another question. He says, I was told that MRD testing was not commonplace yet, and he has not had it. Would you recommend it, that it is critical, and should I push for it?
I mean, we don't know how to use MRD testing at this point. I mean, there's a lot of evidence out there that people who have deeper responses, so they get rid of as much disease as possible in almost any setting, do better. But right now, we don't know what to do with that information, and particularly if you've already had a stem cell transplant, it's not clear that anything would be done with that information. So I think more to come. If the trial that I showed you using MRD testing after induction therapy ends up showing that there is a role for it in that setting, I think it will become commonly used. It is FDA approved, but again, we don't really know how to use it, so I wouldn't necessarily pursue having that done at this point, and insurance may not pay for it in certain settings.
It's not FDA approved for mantle cell. It is for other cancers, I believe.
Yeah, I think you can get it done. I think a lot of times if it's approved in one lymphoma, we can get it done, but that may have implications for reimbursement. Yeah.
Correct.
Thanks.
Okay, Marilyn asks, Marilyn says she came in late and came on when MRD blood probe was being discussed. I think maybe we just talked about this. Is this an FDA-approved test and widely available?
It's easy to order, but again, it may not. We don't know what to do with the results necessarily, and it may not be reimbursed. So would not, outside of a clinical trial, would not suggest using this at least at this time.
Okay, well, here's an interesting question from Rick. He says, I lost 2 nights sleep due to DIH. Has methylprednisolone shown to be as effective as chemo support? Maybe you want to explain what DIH is.
Is it drug-induced hepatotoxicity? So he's asking.
I don't know if that would cause sleeplessness. I wonder if the steroid pre-medication can cause patients to be have insomnia and be hungry and then have a little bit of a crash a few days later as those steroids wear off. Steroids are very effective for nausea. So we often use dexamethasone. Methylprednisolone is a different steroid, but depending on the dose that's used would probably have similar effect. I think that, Sharon, do you?
Okay, oh, he's writing here dexamethasone-induced hiccups. So we do often see hiccups that develop after treatment. And so in regard to that, recommendations we say for use of that, sometimes a drug called compazine can be helpful, and that sort of nausea medicines can be helpful. And then baclofen is another one that we often use, which is a muscle relaxer, can be helpful for treating those.
And I recently had a patient who, it wasn't my recommendation, but I was impressed at the efficacy for this individual patient using gabapentin or Neurontin, which is a drug that's used for nerve pain and has a number of effects, but it was extremely effective in a patient who had hiccups. So yeah, good question. DIH, never heard that before. Learn something every day. Drug-induced hiccups, got it. Dexamethasone-induced hiccups.
So his question was, is methylprednisolone as good as dexamethasone? Did you mention that?
It should be. I mean, we tend to use Dex. I don't think there's any studies comparing those head to head. And methylprednisolone may have the same toxicity. I don't know if anyone knows any different, but you could try it, certainly, use an equivalent dose of Dex and see if it's better tolerated. And, often when patients get hiccups with therapy, it's not necessarily reproducible every cycle. We often see that it will happen with one cycle, often the first cycle, and then subsequently may not happen at all. So
I found that I had less hiccups when I had it when I had the steroid given IV rather than orally. So maybe that may have been idiosyncratic, or maybe that makes some difference.
interesting.
What do you think causes the hiccups? I mean, what about the steroid?
I don't think we really know. I mean, hiccups are, abnormal, function of the diaphragm, and why, steroids can definitely cause irritation of the stomach, but that's sort of a separate issue. So that's a good question. Google it as we're going through more questions and see. I'm sure someone out there may have some idea why it happens.
Right. Okay, here's a question from Matthew. He says, could you elaborate a little more on the patient who has a genetic mutation of chromosomes 11 and 14, and maybe elaborate a little bit more on genetic mutations in general?
So it's not actually a mutation. A mutation means that a certain gene has a mistake in the coding of it, in the DNA coding. The 11-14 is a translocation, so a part of the chromosome which encodes many different genes breaks off and reattaches, and it leads to too much of that protein being expressed in the tumor cells. So it's not specifically a mutation. Patients with mantle cell lymphoma can have other chromosomal translocations, and there are a number of different mutations that can be seen. the one being most important, this TP53 mutation, which we tend to see often in patients who have very aggressive disease, and it may impact on how we treat. But the translocation of 11 and 14 is sort of the hallmark of mantle cell lymphoma, though there are a small subset of patients with the disease who do not have it, and it seems to behave similarly and look similarly under the microscope, though it's probably a slightly different disease.
Dr. Case, can I ask you to elaborate a little bit on whether a genetic abnormality happens hereditarily or spontaneously?
We think that these are sporadic mutations for the most part. Occasionally we do see families where there are multiple cases of, I've seen multiple cases of mantle cell in a family, or patients who have multiple different types of lymphoma within a family. And we don't really know a lot about what those mutations that drive this are. With mantle cell, we do know it is more common in farmers, and there seems to potentially be some impact of environmental toxins. So when it's happening in families, is that a genetic event, or is it related to a common exposure? And I think this is something that obviously needs a lot more research and is an open question at the moment.
Okay. Howard asks, do you know of any studies with patients receiving Pirtobrutinib? Dr. Wang has stated that it could be used before other BTK inhibitors, and so both regimens could be effective for periods of time.
So Pirtobrutinib is a BTK inhibitor, which is slightly different. It's what's called a non-covalent binder, and it appears to have a very nice safety profile. So the preliminary studies show in patients who've had other BTK inhibitors, the drug does seem to be active in a substantial proportion of patients. So, I think the question is, when will this be approved? It also is active in CLL. So we're hoping this drug gets approved sometime soon. And then the question is it more active than our standard BTK inhibitors, Ibrutinib, Acalabrutinib, and Zanubrutinib? So, comparing those side by side may be interesting, but it is a very exciting drug, and we're hoping to get that available soon, particularly given its toxicity profile.
That makes me wonder, and this is for any of you, are there any other promising treatments on the verge of FDA approval right now or in the pipeline that are, there's a lot of expectation about?
So some of the novel CAR T cell, allogeneic CAR T cells are pretty early. And there are also bispecific CAR T cells that target more than just CD19. They target multiple proteins on the cell surface. I think those are exciting. And then there's a whole class of drug called the bispecific antibodies. So they're like Rituximab in a way, in that they bind to a protein on the surface of the tumor cell, but on the other end of that drug is a receptor for CD3. So CD3 is on T cells. So it's a way to bring the patient's T cells to the tumor cells, in some ways, kind of like CAR T cell therapy, but it doesn't require the personalized generation of the product for, it's what we call off the shelf. So you have this available, and there are a lot of studies there's at least 4 of these targeting CD20 and CD3, which are looking very, very promising across multiple different types of lymphoma. So we're very excited about those drugs, and CAR T cell is very expensive and toxic. When you see the neurotoxicity, it's very frightening for patients. Yes, it is very rare that it is life-threatening, but these other safer things are likely to come along, and over time, the field is just really moving in a very exciting way. I looked up the steroid issue, and it appears that the steroids affect the midbrain directly. So it's a central effect, not an effect in the body on the diaphragm itself. So, whether because dexamethasone is a steroid that does penetrate the brain very well, maybe it would be more associated with hiccups than, say, methylprednisolone. So that's a good question.
Okay. Pushing the boundaries here.
Well, Google, you got to look it up. This is our life, right? There's so much information. When I first started, you didn't have to turn and look things up every other minute, but the knowledge has just exploded, and that's a great thing. So we are just lucky to be in an era where we have all these great resources.
Yeah, like Larry said, don't be afraid to Google.
Right. And when you have Larry who can tell you where to Google and what to look at, that is really, really helpful.
Okay, we have another question. This is from Julie. She says, thank you for this. And what is the recommended standard treatment in available clinical trials for MCL patients with TP53 mutation?
Yeah, so TP53 mutations are common in chronic lymphocytic leukemia. So we're sort of taking a nod from the therapies that have been very effective in those diseases. And there are a number of studies combining BTK inhibitors, which are active, as well as venetoclax, which is what is called the BCL2 antagonist, with a CD20 antibody. So there was a recent study that was done at Memorial Sloan Kettering and at Mass General Hospital, led by Dr. Jacob Sumarai, looking at this combination up front. And we'll have to see how it pans out, but I think it's a very appealing strategy because it's a non-chemotherapy approach, and we have the track record in CLL. So, I'm sure there are other trials. We're going to have a similar trial open at Dana-Farber looking at this combination, but I'm sure there are plenty of other trials out there, clinicaltrials.gov, or talk to your oncologist who can help guide you to find a trial.
Okay. Rick asks, could you discuss the R-DHAX regimen a bit?
So R-DHAP was the original regimen. It's Rituximab, cytarabine, and cisplatin. So cisplatin is an older chemotherapy drug, which is quite effective in many different types of diseases, but can cause significant, particularly kidney toxicity and nerve toxicity, particularly involving the ears. So patients can have hearing loss. So it is a drug that I really don't like. And it's been very nice to see that there's some data now out there replacing cisplatin with carboplatin or oxaliplatin, as in the DHAX regimen. And these appear to be equally effective, though not compared head to head, and have a much more favorable toxicity profile. Carboplatin is a very good lymphoma drug, but it also causes a lot of suppression of the bone marrow, and that is the major toxicity of cytarabine. So when you give those two together, you really knock down the blood counts dramatically. So oxaliplatin is a little bit less myelosuppressive in that way. So it's a good regimen, and I'd love to see it completely replace DHAP, but that's my personal. You see, when you see a patient who develops a severe toxicity from a drug, it really colors, how you see things for a while. And if you see one person have bad kidney problems, it just sort of, when we have other alternatives, rather use those. So.
Larry, did you have something to add to that? Okay. Here, Hassan has something to say. She's my mother had MCL at 59, now 74, R-CHOP 221X8, and R-MAINT. And now my daughter was just diagnosed with B-cell Lymphoblastic Lymphoma at 16. Is this a coincidence or something to do with genetics?
I'm so sorry to hear that. Your mother, that's quite remarkable. With R-CHOP, rituximab has done so well, and there is a study that has shown that strategy to be effective, though we're not using it as much anymore. Now we have some newer treatments. B-cell lymphoblastic lymphoma is not, it's different from mantle cell lymphoma in that the cell that it arises out of is a premature, it is not a mature B cell. Mantle cell is a mature B cell, so it's a much, when you look at how B cells mature throughout their lifespan, it's what's called a precursor B cell and the mature B cell. So B-cell lymphoblastic lymphoma is a precursor B cell disease, and it's really treated by our leukemia colleagues because it is treated exactly like B-cell acute lymphoblastic leukemia, which is the most common leukemia seen in kids and adolescents. So whether this is just purely bad luck, or whether there is, it's two different points in the B cell, it's hard to say. And we definitely see these things, and we always scratch our heads and wish we could say more. But hard to know whether it's a coincidence or related.
If someone has a family member, or someone has two family members with MCL, for example, is it often that the same type of treatment helps them, or is it always different?
In general, the therapies for mantle cell are very effective. So, it's really the duration of remission that may be more variable. And I think we don't really know in relatives. And, if they're siblings, we might use a similar sort of approach because they're going to be relatively the same age. But when there's differences, I've seen a father and son combination a couple of times. So that may actually determine more than anything how we might approach treatment.
Here's a question from Robert. He says, I'm going to start BR in about 6 weeks. I've had 3 COVID vaccines, good for you, and Pneumovax, 1 shingles, and we'll get the flu vaccine. What other vaccines should I get before starting, and how soon before?
Yeah, so we would recommend that you do receive both pneumonia vaccines. So you've had the Pneumovax. The second one is called Prevnar, which was historically a pediatric pneumonia vaccine, but now is recommended by the CDC for any immunocompromised patient to also receive Prevnar. That's the 13-valent pneumococcal vaccine. So we recommend receiving that just anytime before the Bendamustine Rituximab. And then if your shingles vaccine should have been the Shingrix, most likely that's what's recommended by the CDC for any heme malignancy patient. That is a 2-vaccine series. And so I would recommend a second Shingrix vaccine. And then if you're not able to get those before treatment, our recommendation is to wait to receive, except for COVID and the flu, to go ahead and wait to receive the other vaccines about 9 to 12 months after you finish the Rituximab. Just it's not dangerous, but we worry that the Rituximab will again blunt the immune response to these vaccines. So if you can get it before treatment, that's great. If not, waiting 9 to 12 months after.
Yeah, I totally agree. And would also add that Bendamustine probably also has an adverse impact on response to vaccines. So keep an eye out for, talk to your oncologist, because this data, now we're really looking at this very closely with COVID. And you can get a COVID vaccine, but, it's very, very unlikely that you would respond if more boosters are subsequently recommended. So it's very tough for our patients because we're seeing lack of response even with 2 or 3 vaccines in people who have had these treatments.
The question is, studies indicate CD5 negative MCL is a distinct variant. My question is whether recommended treatments are any different for the CD5 negative variant, and if so, what are the considerations?
Do you want me to take that one?
I'm sorry, yes, please, Anne, please answer that one.
So CD5 negative mantle cell lymphoma is a rare subtype. It's about 5% of cases, and it may be associated with a better prognosis. But I think the problem is, you know, in terms of trying to figure out whether the therapy should be different, that would need to be studied in, you know, clinical trials. And when we're talking 5% of a very rare lymphoma, you know, I think we're just looking at sort of case reports. So, you know, I think at this moment in time, we would probably manage a CD5 negative mantle cell lymphoma in the same way. This has cyclin D1, the mechanism of growth and survival of the cancer cells probably has a lot of similarity to CD5 positive mantle cell. Maybe more to come in the future, but at least from my knowledge, we wouldn't do anything differently.
Okay. Another question is a two-part question. In the longer term, and I think this is for you too, in the longer term, do you see CAR T therapy replacing the need for allogeneic stem cell transplants in the second, third line strategies, or will the treatments be complementary? The second part of the question is, would it be possible for a patient to be treated with an allogeneic stem cell transplant and then later by CAR T therapy?
So at this point, you know, I think CAR T is replacing allogeneic stem cell transplant, which had been really our only option for patients who had relapsed after an autologous transplant to have long-term disease control. And now we have CAR T cell therapy. So we are definitely referring many fewer patients to allogeneic transplant. One of the issues with doing CAR T cell therapy after allotransplant is that, or after autologous transplant rather, is patients often have had you know, a pretty high burden of chemotherapy, which, as Sharon pointed out, can cause stem cell damage. And when we do CAR T cell therapy, we have seen some patients who, you know, with that lymphodepleting chemotherapy have developed even more difficulty with bone marrow counts and things, and have needed allogeneic transplantation to sort of replace the damaged bone marrow stem cells. So it's a little bit different. You're really looking to replace the stem cells as opposed to specifically treat the lymphoma. I think, you know, we're going to need more data moving forward. Thus far, you know, as Larry just pointed out, the follow-up for these mantle cell study, the mantle cell study is quite short. So we don't really know what's going to happen over time. We're very encouraged because in diffuse large B-cell lymphoma, the recurrences were relatively early if they were going to happen. So we need more time to really fully assess this. You can certainly do CAR T cell after allogeneic stem cell transplant. You know, presumably it sort of depends on the state of the stem cells. You know, sometimes those will be, you know, they won't engraft well and they may disappear over time, and then you're sort of left with very low blood counts from the recipient. But this is definitely a strategy that has been done.
Okay. Sharon, this might be a question for you. What are your thoughts on the emerging therapy Pirtobrutinib?
So all the emerging therapies are meant to try to continue effectiveness in treating the mantle cell and decreasing side effects. And so, you know, we are eager to see if that's the case. The longer we have these therapies, the more we will know. But that is the goal as we develop all of these emerging therapies. As Dr. Lacaze mentioned, Ibrutinib initially, you know, there was the concern, or is the concern about AFib, and then acalabrutinib less so, zanubrutinib less so. So that's the goal.
Okay. This is a question for anyone that can answer it. How many MCL patients are actually receiving CAR T cell therapy in a year? Any guess?
It's very hard. I have not seen any numbers. You know, as Larry pointed out, you need registries where patients are, you know, we could certainly get that information from, there's only one company right now that is manufacturing these cells. This product, we're doing a fair number. We do, several per month at our institution, which is one of the bigger ones in terms of CAR T-cell therapy, but I don't know an actual number, but it's, it is becoming a commonly used strategy.
Right. Larry, were you going to say something?
No.
Okay. Bear with me on this one. How long, on average, is needed for the combination of Ibrutinib and Rituximab for relapsed MCL patients with blastoid variant? Is CAR T the next path?
So, honestly, I don't recall the numbers. Blastoid is a relatively small percentage of patients with mantle cell, fortunately. We do know that basically in any therapy, blastoid, with the exception possibly of CAR T-cell therapy, that the duration of remission is shorter than with patients who don't have blastoid. So, it's likely, less than a year. Though not all blastoid are the same, and it's hard to apply statistics to an individual, as we heard. CAR T-cell therapy would be, for a patient who had progressive disease after Ibrutinib plus Rituximab, that would definitely be in the, in an appropriate candidate would be the next typical treatment.
Okay. I have a question for any of you. There's been a lot of focus on new treatment like CAR T therapy, but mantle cell is often diagnosed at an advanced stage. Are there any developments for earlier diagnosis?
So, picking this disease up early doesn't necessarily change outcome. That is something that is very different about lymphoma and solid tumors, because we're not surgically treating this disease. And we really don't know that treating when patients have less disease actually leads to longer remissions. And in fact, if that were the case, we probably wouldn't be recommending active surveillance for patients. There would be a strategy to treat people right away if we had seen that was a benefit. So I think it's less about early detection. If we knew what caused mantle cell lymphoma, maybe, prevention perhaps. We're nowhere near that at this point. I think our focus is really on developing effective treatments for people who need treatment.
Okay, thank you.
We sometimes detect mantle cell just on other health screening treatments, such as screening colonoscopies. So encouraging patients to keep up with that is something certainly to do, because sometimes, as Dr. Lakay said, it is diagnosed that way. So that's one reason we do diagnose these cases. Sometimes, scans done for other reasons, detecting lymph nodes, but no other reason really to detect it sooner.
Okay. Okay, another question coming at you. Sorry. Here's a person coming from mantle cell from a solid tumor background. Can you expand on consolidation therapy prior to SCT? About how long does this last, and what metrics do you look for to end the therapy?
So the consolidation therapy is the stem cell transplant. There's induction, and then the consolidation part means intensifying the treatment to try to eradicate any cells that might have survived the initial induction. The studies have shown that with patients treated in clinical trials using stem cell transplant in the era of Rituximab, the sort of average duration of remission is more than 5 years, and can be significantly longer. We look for complete response. At this point, we're not typically assessing for minimal residual disease outside of a clinical trial, because we don't know that treating that early necessarily results in better survival. So we generally look at PET scans. You know, sometimes we repeat bone marrow biopsies if there is, you know, to evaluate for persistent disease in the bone marrow. But generally, we would do the maintenance Rituximab, which has been shown to improve outcomes. And we typically, you know, get periodic scans.
Okay. Here's a question. Can you repeat what needs to be checked in the blood if you take Rituximab?
So if you're receiving Rituximab, I'm not sure if the question is asking for the immunoglobulin discussion that I had briefly on my slides, but checking in regard to the immunoglobulins in the blood to see if those are low, because B cells make immunoglobulins. So if you're on maintenance Rituximab, it's important to follow that along, because if your immunoglobulin levels are low, then you may need replacement immunoglobulin or IVIG. And then other maintenance blood work that we do in patients who are in a maintenance phase after mantle cell treatment is routine blood work, complete blood count, comprehensive metabolic panel, including electrolytes, liver, kidney tests, and usually the LDH marker as well. It's typically the blood work that we monitor at subsequent visits.
So there's always a lot of blood work after any treatment.
That's right.
Yeah, I would just add, I totally agree. You know, the LDH is a non-specific blood test, so I think sometimes patients are looking very carefully at all of their labs and may have little minor variations that are not clinically important. So don't assume that if your LDH is a little elevated or even significantly elevated, that it's definitely related to the lymphoma, because there are many other reasons it can be elevated. And with Rituximab maintenance, sometimes people get low white blood cell count. And we sometimes stop the Rituximab maintenance. Fortunately, although some patients do get low IgG levels, we would only give replacement if patients are having recurrent infection. And usually in that setting, we would stop giving the Rituximab. So it's, you know, it's an ongoing decision about whether, you know, weighing the risks and benefits for each individual patient.
Okay, here's another question on Rituximab, if you don't mind. Do you have any more comments on the effectiveness of Rituximab maintenance after using Bendamustine Rituximab treatment?
Yeah, it's controversial. So there was a small study from Germany that took patients with mantle cell who had Bendamustine plus Rituximab and then gave them maintenance or no maintenance. And this was a small study, but there was no difference. And we think perhaps that relates to the impact that Bendamustine has on other immune cells. That being said, you know, I think some of us do use it if patients are tolerating it, because that was a small study, and we have used maintenance Rituximab in other settings, other subtypes of lymphoma. But it is worth, you know, again, a lot of this is about discussing with your provider the pros and cons of each step that you take and making a decision together about what makes sense for you.
Another treatment question. There are trials currently ongoing with Ibrutinib plus BR regimen in the first line MCL setting. What are your thoughts on that?
Sorry that I'm answering all the questions. If anyone wants to jump in, please feel free to pipe in. You know, I suspect that that will be a positive study. Ibrutinib is a very active drug. You know, it is associated with more side effects than the next generation molecules. But you know, I suspect we'll be moving in that direction. And, you know, the question then becomes, do you need the transplant, and where does CAR-T fit in? And I think now that we have a lot of good options, these are what our, you know, trials moving forward are going to ask. But I do suspect that'll be a positive study. It'll be interesting, however, to see if there's any added toxicity, particularly using Ibrutinib with Bendamustine in terms of infections and other side effects.
Right. Okay. besides CAR T and stem cell transplant, are there newer drug regimens being used for relapse of mantle cell, possibly before either of these?
So, it all depends on what the initial therapy was. A lot of patients have had Bendamustine-based regimens or cytarabine, and if they relapse and then we would typically go to a BTK inhibitor. Venetoclax is what's called a BCL2 antagonist, and that is a drug that, has been studied in mantle cell. The studies are small, and the activity is variable in these studies. We sometimes combine it with BTK inhibitors. There's evidence to show that the rates of remission are higher with deeper responses. There are some chemotherapy drugs, lenalidomide, which is it is a chemo drug. It's an oral chemo drug. Cytarabine, you can use in low dose in older patients who haven't had it previously, and that can provide palliation. The other thing to know for mantle cell is for someone who's not a candidate for aggressive treatment, radiation is actually a very effective way to treat mantle cell. And if there's one, we obviously don't radiate the entire body and, radiate multiple different sites, but can be extremely helpful when patients have a symptomatic lymph node or mass, and sometimes very low dose radiation, which has, almost no toxicity, can be very helpful. So there are a lot of things that are available, and they're just getting better and better. And there are a lot of clinical trials that include mantle cell. Unfortunately, because this disease is understood better than a lot of other lymphomas with the 11-14 translocation, this has led to scientists being really intrigued by this disease. And there are, the Lymphoma Research Foundation has a meeting every couple of years just focused on mantle cell, where the scientists come together and talk about what they've learned, and this translates into new treatments. So it's a very interesting disease.
There are also some individuals on our groups that have had one treatment and gone 3 or 4 years, and had another treatment and gone 3 or 4 years, and they're actually out 17 to 20 years, although it gets harder and harder to treat. Sometimes with localized radiation. So we've definitely seen people, although it's a small subset, that can go for a long time by having multiple variations of these various treatment modalities.
Okay. Let me throw you a curveball. Are there any questions you'd like to ask one another, or any points you'd like to bring up from one another's presentation? Larry?
No, thanks.
I have a question for Larry. What advice would you give to Sharon and me in terms of how we approach our patients? Just general advice coming from the other direction. We always love to hear what we can do better.
Well, I think one of the things that's important is trying to take the terminology, which is more and more complex, and make it accessible. People come back, and they'll write on our group and say, they said this, they'll say, I was stage 5, for example. And they confuse the staging system with the staging system for the PET scans, for example. So there's so much terminology that it's easy to get lost, but you don't want people not to participate. You're really trying to get to a point where you have a shared decision making, and to bring those people up is difficult. And that's one of the things that we can do in the groups if people know about these groups.
Okay, well, that might be a good place to wrap it up, unless there's any other comments you have.
I'll just address I saw this question for me. Lenalidomide, it's a newer drug, but we would consider it to be an oral chemotherapy. It's not an it has different effects on cells, and it's sort of down to, how you define things, but I would consider it to be an oral chemo drug. It's just one of the newer drugs.
Okay, very good. All right, well, thanks for your time. Big thank you to our presenters. NCCN Foundation would like to thank AstraZeneca, the corporate sponsor of this webinar. And thanks for everyone who attended today.